Welcome to another episode of Talking with Docs. I'm Dr. Brad Wiening.
And I'm Dr. Paul Zalzal.
On today's episode, we're going to be talking about Achilles tendon ruptures.
Yes, this is a common one. See a lot of these, and it is fairly controversial.
Very controversial topic, important one to discuss.
Yeah, okay.
Let's start with the tendon, Paul. What's the Achilles tendon?
Here.
Oh,
I happen to have a model of a foot right here. So the Achilles tendon is a strong tendon that comes from all the muscles of the calf coming down together to form one tendon and inserting into your heel bone or your calcaneus. And it is responsible for you being able to stand on your toes, for example, or flex your foot.
Or really push hard on the gas pedal.
Or pedal to the metal. Right?
Pedal to the metal. Okay, so who gets this injury?
So the person who gets this injury is what we refer to as the weekend warrior.
Okay, so commonly playing sports, football,
Yeah.
frisbee, trying to live out the glory days.
Yeah, so you're, can be a fairly athletic person or not so athletic person who suddenly decides to take up a sport or
Yes.
hasn't played baseball in, 10 years and all of a sudden wants to get a home run and sprints off home plate, that kind of thing.
Tries to leg that single out to a double.
There you go. Yeah, exactly. So it's a sudden contracture of your calf muscles that is just too strong a pull and tears the Achilles tendon.
Do people typically complain of troubles with their Achilles tendons before this happens?
Yeah, that's we do see that often. Someone will say, "Oh, I've been having some pain behind my ankle," or "I've been even diagnosed with Achilles tendinitis." So a tendinitis is just inflammation of the tendon, and then that can predispose you to a rupture, or it can happen without that history beforehand.
And so usually people have that time when they feel something acutely has happened,
Yeah.
sharp stabbing pain. Sometimes people describe it as like a knife in the back of my calf.
That's right. So yeah, often someone who's playing squash will say, "Oh, I felt like someone hit me in the back of the calf with a squash ball," or some people even hear the snap, sudden pain, can't weight bear.
Can't weight bear. And yeah, so that inability to push down because the muscle's disconnected from the ankle.
So should you walk this one off?
You definitely should not try to walk this one off. A, because you can't, you'd look weird.
Yeah.
And B, because if you don't get it treated initially, it certainly can compromise your outcome significantly.
Absolutely. Yeah, your outcome is very dependent on getting treatment for this quickly. If you wait a few weeks for this one, your outcome can be very poor.
So you go to your walk-in clinic, your emergency room, or potentially even your family doctor, I guess. And how's it diagnosed, Paul?
So history first. Things that we talked about, the sudden onset of pain while doing an activity, and then your physician will do a physical examination looking for.
So some swelling, some bruising. Often they can palpate an area where the tendon is no longer there, so there's like a little divot on the back of your lower calf. And then there's something called the Thompson test.
Yeah, they may do a fancy test on you called the Thompson test, where they lie you on your stomach and then squeeze your calf and see if your foot plantar flexes, or if you sort of push down with your foot. Because as you squeeze the calf, if your Achilles tendon is intact, will make you flex your ankle and try and point your toes. If that doesn't happen, it means the Achilles tendon, or it suggests that the Achilles tendon is ruptured.
Sure. X-rays usually normal.
Yes, actually usually normal.
And then often people will get an ultrasound or
Right.
potentially an MRI, I guess, depending on the setting where you're practicing or where you're living, to confirm or rule out the tear.
Right. Okay. So now let's say I've gone to my doc. I've been diagnosed with an Achilles tendon rupture. What's the initial treatment that usually you get?
So just like first aid, you usually splint it.
Right.
And it's very specific for Achilles tendon tears is that you splint the leg with your foot hanging down or in what's called resting plantar flexion. So approximately 20 or 30 or 40 degrees, something that's comfortable with gravity, holding the foot down so that it actually theoretically brings the ends of the tendons closer together while you're splinted.
Yeah.
Typically for 2 or 3 weeks, sometimes with plaster, sometimes with fiberglass, whatever they use at your facility.
Right. So toe pointed down like a ballerina. I tell my patients, point your toe like a ballerina.
Nice. Ballerina. What if you're a weekend warrior? You probably don't want to be a
Weekend
ballerina.
warrior. True. You don't want to be a weekend. That's probably why I let my kids win when we play basketball, because I don't want to lunge board and rupture my Achilles tendon.
Or be a ballerina. Not that there's anything wrong with that. Yeah, sure, whatever.
It pays well.
So then you go and you get referred typically to an orthopedic surgeon, and you're seen initially. How long are you in that splint?
Okay, so you got that initial splint with your toe pointed down until you see your orthopedic surgeon. Well, that's when the decision comes in now, really, the controversy. Once you've been splinted for 1 or 2 weeks, or however long it takes for you to get to see your orthopedic surgeon, now you've got the decision to make. Do we keep going with non-operative treatment, or do we treat this surgically?
And this is controversial for a bunch of reasons, because as time progresses, the treatment options have certainly changed. And I'd say 25 years ago, everybody got surgery, and then it's kind of swung back and forth from everyone not getting surgery and everything in between. And that's because technology has improved. So what are the main benefits of surgery?
Okay, so if you're thinking of a surgery for this, the main benefits that we think occur from the literature, from the scientific literature, we find that the re-rupture rate, okay, so the chance of this happening again while you're recovering, is a little bit less if you operate on it.
Yeah.
One. Some of the evidence we have says that if you heal, it can be slightly stronger if you treat it non-operatively. If you treat it operatively. So lower re-rupture rate, slightly more strength. And some literature we have, and some people say that you can recover quicker if you operate on it. Now this makes it sound like I'm someone who prefers surgery, but I'm not saying that. I'm just saying from the literature and what advocates of surgery would say, these are the things they're going to tell you. What about non-operative treatment?
So the benefits of non-operative treatment, I'd say the first one is that you get to avoid the risk of surgery, which may be very low, but certainly are still real. They're not zero.
Yeah, and on the risk of surgery, you've got to remember that Achilles tendon is very subcutaneous or very superficial. So whenever we operate on superficial structures like that, there's an increased risk of infection.
Yeah, risk of infection, risk of a large wound slough where all the skin does because of the blood supply, general risk of surgery like heart attack, stroke, infection locally, all those things certainly are a risk of surgery. With non-operative, one of the main benefits is that you get to avoid the risk of surgery. And then the other proponents of non-operative treatment say, well, the risk of re-rupture is low in both cases. It's somewhere in the range of 2 to 10% on both sides, and it's very close between the two. And that people don't have to be admitted to hospital, there's a lower associated cost, and that ultimately at 1 year, they feel that the function is actually quite close.
Right. So that's why it's so controversial, because the outcomes of both operative and non-operative are both very good. So it's very difficult for you, the patient, and for the surgeon to decide what the best way to go is. But definitely, if you're in this situation, talk to your doc. And it doesn't hurt to get a couple of opinions if you want to find out what's best for you, operative or non-operative management. Personally, I think I've treated more non-operative Achilles tendons than operative.
I would agree. Way more for sure.
Yeah.
Just because I think now. Well, let's talk about your non-operative treatment. So after you're in the splint, say you're at 2 or 3 weeks, what now? I'm in the splint. Am I just in the splint for ever?
That's it. You got splint forever, and hope you don't get 2, because then you're going to have to walk around 2 splints forever.
That is not true. So after the splint, you change to a boot typically.
Yeah. So there's a lot of different non-operative protocols, but generally they consist of starting with your toe pointed down, and then in some form of immobilization, splint or brace, and gradually bringing your ankle up and up and up. Once you get to neutral, then you can start walking on it, which is around 4 to 6 week mark, and then in the splint, and then gradually after the 6 week mark, you start a strengthening protocol to get it strong again. So you're looking at a good 3 months of working on this Achilles tendon.
And I think that's the biggest difference for non-operative treatment, because even when I was a resident, I remember we used to cast people with their toe down and then bring them back 2 weeks later and then cast them in a different cast and then a different cast. They're always in a cast, but at least in the boot, people can take it off to wash, and it's readily adjustable. And even once you get walking at 6 or 7 weeks, it stops your toes from coming up, which stresses the repaired tendon, but allows you to push down. So you're geting a little bit of active physiotherapy while you're in the boot before you're even
so these are these new boots that we have available to us that replace casts. It is, any way you look at it, operative or non-operative, it's a fairly long recovery period for the Achilles tendon. 3 months, sometimes up to 6 months. What about sports? When can I get back to my weekend warrior activities?
I tell people 6 to 12 months, and certainly I want people being able to do a single toe raise before they can get back to sports, and often that is 6 to 12 months. And it's frustrating because it's the 42-year-old guy that maybe likes to run 5K or play football, or a woman that actively plays tennis or racquetball or something. So the people are often frustrated. It's a slow process, but they get there.
I agree. I use that same marker too when I ask people once when I'm following up, can you stand on one leg and go up on your toe on that leg? And that's an indication that your strength is pretty good. And generally for returning to sports, I tell people once you're at 80% of the strength on that side compared to your good side, and you've got 100% of the range of motion, then you're safe to go back to your sports.
I think the one thing for both of them that I think we failed to mention that's important is, especially in the early phases, Achilles tendon tears are sore at the beginning, but then they typically should get less sore. So if you do happen to have calf pain in this setting, you just want to discuss with your treating physician whether or not your pain is increasing and still appropriate for a tear, or potentially is related to a blood clot. Because any injury to the lower leg where you're immobilized and not walking normally increases the chance that you could get a blood clot, and that could mean potentially further investigations or possibly treatment to prevent or treat a blood clot. So just important for people to be aware of. If you get that calf pain, chest pain, shortness of breath, back to the emergency room. Right,
a DVT, deep vein thrombosis, or a blood clot. I actually, for my patients, I'll put them on some sort of blood thinner for the first 2 weeks, or until I let them start moving more. And usually I choose, if they have a history of blood clots, I'll say you're going to take something like an injectable blood thinner or an oral blood thinner, like a strong one. If you don't have any risk factors or you haven't had a blood clot before, then usually I'll just tell all my patients to take a baby aspirin a day to help minimize that chance.
Yeah, great.
That's it. Anything else?
I think that just about covered it. Oh, do people ever have it on both sides?
Yeah, I mean, I don't think I've ever seen it at the same time on both sides, but I've seen someone have it.
I did have one lady both sides. She was like an older lady, and it's a big problem because you can't.
What was she doing playing basketball?
She
jump shot?
No, she wasn't. She had spontaneous kind of ruptures of her Achilles tendon, so she had some other medical problems that sometimes are related to teres of her tendons, but yeah, very complicated to treat, obviously.
Yeah. Did you go operative or non-operative?
Non-operative on both sides.
Nice.
Yeah.
Okay, yeah, I can't think of anything else. So if you have any topics that you'd like to discuss,
please email us at talkingwithdocs@gmail.com.
Thanks for tuning in, and remember, you are in charge of your own health.
See you next time.